Hello, welcome to the Functional Lab. The experiment we'll learn today is hemorrhagic shock and treatment in rabies. As we know, the blood is the essential substance for life. Well, do you know how much blood there is in the body? How much blood loss will lead to hemorrhagic shock? What's the pathogenesis of shock? What are the clinical manifestations? And how to treat it? Today, let's replicate a model of hemorrhagic shock and find the answer in practice. At the first part, let me introduce the experimental principles. What's the shock? As we know, the shock is a dangerous, systemic, pathological process under the action of various physiological factors, characterized by acute circulatory failure, including decreased effective circulatory blood volume (ECBV), insufficient tissue perfusion, cellular metabolism impairment, and dysfunction of multiple organs. Hemorrhagic shock is the most common type of shock in surgery. The blood volume of a normal adult accounts for 7 to 8% of the body weight. Generally speaking, if blood loss is less than 10 to 15% of total blood volume within 15 to 20 minutes, the blood can maintain blood pressure and tissue perfusion basically normal by compensation. Rapid blood loss of more than 20% of total blood volume will cause hemorrhagic shock. If blood loss exceeds 14.5 to 15% of total blood volume, the patient dies quickly. Although the etiology and initiation of shock are different, microcirculation disturbance is the common basis of most shock. The key to the occurrence of shock is not the decrease of blood pressure, but the changes of microcirculatory blood flow. Taking hemorrhagic shock as an example, the typical development of shock includes 3 stages: ischemic hypoxia stage, stagnant hypoxia stage, refractory stage. Firstly, massive blood loss will cause the activation of sympathetic adrenal systems, resulting vital constriction, increased peripheral resistance, and decreased blood perfusion to tissue. The microcirculation enters the ischemic hypoxia stage, characterized by small vessel contraction, slow blood flow, and closed capillary network. If the time of ischemic hypoxia is quite long, it will cause acidosis, increased vasodilators, and hemorrhagic changes, resulting in capillary dilatation, red blood cells aggregation, leukocyte adhesion, slow blood flow, and blood stasis. Microcirculation develops into stagnant hypoxia state. Continual disease development will lead to disseminated intravascular coagulation, DIC. Microcirculation will develop into refractory stage. Perfusion stops. The patient gets worse. Therefore, we can draw the conclusion that improvement of microcirculation and tissue perfusion is the central link of the shock treatment. So, how to improve the microcirculation? Firstly, supplement blood volume, increase ECBV, and improve tissue perfusion. Secondly, correct acidosis and improve vascular response to vasoactive agents. Furthermore, on the basis of effective tissue perfusion, improve microcirculatory perfusion and cellular metabolism by reasonable application of vasoactive agents. So daughter, pay attention the key sentence. The key to the occurrence of shock is not the decrease of blood pressure, but the changes of micro blood flow. So the central link of treatment of shock is to improve microcirculation and improve microcirculatory blood perfusion. The purpose of this experiment is to replicate hemorrhagic shock in rabbits by arterial bleeding. Next one, effects of shock on the body are manifold. Please pay attention to the changes of blood pressure and microcirculation, as well as the respiratory, cardiovascular, and urinary functions. The experiment aims at helping you understand the pathogenesis and treatment principles of hemorrhagic shock. So during the experiment of shock, please understand the pathogenesis and treatment principles according to the results of experiment. Healthy rabbit is used as experimental subject. Next one, experimental materials include the BL420 biosynthesis, BI2000I medical image analysis synthesis, and we will use respiratory transducer, blood pressure transducer. One is for arterial blood pressure, one is for central venous pressure, and the rabbit surgical instrument. This is bladder cannula, tracheal cannula, venous cannula, arterial cannula, heparin to anticoagulation, uracil for general anesthesia, normoxilin, norepinephrine, anisodomine, and rabbit blood are used for shock treatment. Now, let's replicate the model of hemorrhagic shock. Part 2, Method and Procedure. This part is divided into 3 steps. One is animal operation. Second one, replicate hemorrhagic shock in rabbit. The last one, treat it. This is an overview of the rabbit. Now we need to insert several incubation. First one, the tracheal cannula. We use it to record respiration. Second one, arterial cannula. We can use it to record blood pressure and draw the arterial blood out to replicate hemorrhagic shock. Last one is venous cannula. We can use it to transfuse or infuse blood and fluid, and we can record CVP. Next cannula is blended cannula. We use it to record urinary volume and reflect the function of the kidneys. The last one is mesenteric microcirculation. We can use it to record the changes of microcirculation. Now, let's continue to see how to do experiment. Take a healthy rabbit. Hold the neck and the back skin with one hand. Support the buttocks with the other hand. Be careful not to hold the rabbit ears, and weigh the rabbit on the baby scales with kilogram. Draw 20% uracil solution at a dosage of 5 ml 1 kg and remove the bubbles. Cut the hair of the ears back by clipper. The marginal vein is located at the outer edge of the ears back. Insert the needle into the vein about 1 cm and inject uracil slowly and complete the injection within 2 or 3 minutes. Use a cotton filament to stimulate the cornea of the rabbit. If the reflex is obviously slow or disappear, and the muscle limbs relax and breath is deep, slow and steady, skin pain response disappear, which indicates successful general anesthesia. Place the rabbit on the operating table in supine position and fix the tooth with a rope and fix it on the hook of the table. Then fix the limbs. Tie the limbs above the joint with the rope and fix them on both sides. Stretch both upper limbs downward and backward and keep the neck straight. Cut the neck hairs with a caliper close to the skin, the rinsing from the lower jaw to the superior border of the sternum and both sides of the neck. Now this is the breastbone, the jaw, about 7 centimeters, and put the cut hair into the water of the garbage to prevent the hair flying anywhere. And wipe the operating fields with a saline and lift the night skin and make a middle incision about 7 centimeters with surgical scissors. Cut the skin carefully and slowly to prevent bleeding. The next one, cut the subcutaneous tissue in the same way. Prevent bleeding. This is the trachea, which is covered by the muscle, so you should cut the subcutaneous tissue and separate the neck muscle with the forceps and expose the trachea. Bluntly separate the muscle. You know the muscle is reaching the vessel. If you use scissors, cut the muscle, it will make bleeding. This is the trachea. The next one, bluntly separate the connective tissue between the trachea and the esophagus and thread a line. Okay, now the next one, cut half of diameter of the trachea between two tracheal cartilage regions from 1 or 2 centimeters of the border of thyroid cartilage, and cut 2 cartilage rings towards the hand. The incision seems like reverse T shape, reverse T, and clean the trachea with the cotton. Next one, insert tracheal cannula towards the lungs and fix it with the line. Next one, contact the tracheal cannula to respiratory transducer and record respiration in the computer. For the next one, we are ready to insert arterial cannula. First one, this is arterial cannula, and fill it with heparin and remove the bubbles out. Next one, separate the left common carotid artery. This is the Winger's nerve. This is carotid artery, and put a double thread under it. Ligate the distal end. And clip the proximal end of the artery with arterial clip. Make a small cut close to the line. And insert arterial cannula towards the heart and ligate tightly. There is heparin in the cannula to prevent blood clotting. Connect artery cannula to blood pressure transducer. Remove the clip. And open the T-pipe and connect the cannula to the computer. We will record blood pressure. The next cannula is Wiener's cannula. This is a Wiener's cannula, firstly connected with the pressure transducer and fill the cannula with heparin to prevent blood clotting. This is infusion site. Fill it with normal saline and remove the air bubble out. Connect infusion site to transducer. The next one, separate jugular vein. This is right side. We use the right external jugular vein. This is the right external jugular vein. This is internal jugular vein. This is common jugular vein. Separate with forceps. Separate connective tissues around the vein and put double lines. This is head, this is heart, this is distal end, this is proximal end. First one, use the clip, prevent venous return. And leg it with the line at distal end. Make a little cut close to the line. Insert venous cannula. There is heparin in it to prevent blood clotting. Remove the clip. Continue to insert cannula about 5 to 8 centimeters until the cannula arrival at the vena cava of the right atrium and fix it with a line. Open the T-pipe and connect the venous cannula to the pressure transducer and computer. Record central venous pressure. The next is abdomen operation, bladder incubation. First one, cut the lower abdomen hairs with a clipper. Well, this is the pubic symphysis. Lift the skin at the superior margin of the pubic symphysis and make a median incision about 2 centimeters with surgical scissors. And cut subcutaneous tissue in the same way. Don't damage the blender. Open the abdomen cavity along the line and move the blender out slowly and carefully. This is the blender. Fill it with urine. This is the ureter. Thread a line under both sides of ureters. And ligate the bladder neck to block the urethra and prevent urine loss. The next, gently lift the top of bladder with forceps and make a small incision in the inferior blood vessel side. And insert bladder cannula into the bladder and ligate with a line. The other end of cannula is connected to the disc and record urinary volume 1 minute, how many drops out, and cover the wound. Well, the next one is mesenteric microcirculation observation. First one, remove the hairs on abdomen and lift the middle skin of the abdomen. Cut the skin along the middle lines about 4 to 6 centimeters and cut the tissues and open the cavity along the middle lines. Select a small intestine loop and put it out and place it under a microscope. We will observe the changes of microcirculation under microscope during the shock. Find the suitable views and observe the changes in the blood flow in the mesenteric microvessels. The next one, observe the normal indicators including blood pressure, CVP, and respiration. And record urinary volume. The drops 1 minute. The next one, use heparin to prevent blood clotting. 1 kg 1 ml is intravenous injected by the venous cannula. This is the venous cannula. This is the arterial cannula. Connect the infusion site to the venous cannula. And the next one, to replicate hemorrhagic shock by arterial blood lighting. Connect injector to arterial cannula. Make arterial blood out. Observe blood pressure after 5 or 10 ml blood drawing out each time until the mean arterial blood pressure drops to 40 millimeter mercury column and maintains for 30 minutes. And record the changes, all the indicators. Collect the blood and record the volume and save it for treatment. The choice for treatment. The first one, transfuse blood or normal saline. The next one, both normal saline and blood are transfused. The next one, transfuse normal saline, norepinephrine, and blood. The last one, transfuse normal saline and anisotomy and blood. 20 minutes later after treatment, please observe all the indicators compared to the indicators before treatment. Part 3. Experimental results. Firstly, let's observe all the indicators before shock. This is arterial blood pressure. Normal range 107 mm mercury column. This is CVP, central venous pressure. The normal rate 4 to 5. This is respiratory frequency. This is normal indicators. Well, after arterial blood pressure, let me see what happened about all the indicators. After arterial blood pressure decreased, dropped to 40 millimeter mercury column, and the CVP dropped to 2. And the respiratory frequency rapid and shallow. Well, next, after the different treatment, what happened about the indicators? First one, this is normal blood pressure, normal microcirculation. Now, begin to draw arterial blood out to replicate hemorrhagic shock. You see microcirculation contraction, and blood pressure drop down until the mean blood pressure can maintain at 40 millimeter mercury column for half an hour. Half an hour later, we will treat the hemorrhagic shock with solution. The first treatment, we use normal saline and infuse normal saline from the venous cannula. After quickly transfuse normal saline or all outgoing blood from the jugular venous cannula with 5 minutes, you see blood pressure slowly increase. And the microcirculation is improved to some degree. This is the first treatment group, blood transfusion or normal saline transfusion group. Quickly transfuse all outgoing blood or normal saline same to blood loss from the right external jugular vein with 5 minutes. That means in this group, only transfuse blood or only transfuse normal saline without any vasoactive agents. Well, this is the second treatment, normal saline and blood transfusion together. After arterial blood lighting for half an hour, quickly transfuse 25 ml of normal saline from the right external jugular vein rapidly, then transfuse the all outgoing blood back quickly and observe all indicators. So firstly, transfuse normal saline. After transfusion normal saline, the microcirculation improves. Some vessels restore blood perfusion, and blood pressure increase slowly. Then transfuse blood. This group seems better than the first group on the basis of normal saline and blood transfusion. But some microcirculation are still under high perfusion. But the next one, let me see the third treatment. Third treatment is norepinephrine and blood transfusion. Firstly, draw the atom blood from the venous, from the cannula, and to replicate hemarrhagic shock and maintain blood pressure at 40 mm per column for half an hour to replicate shock. Half an hour later, begin to treatment. Now for this treatment, firstly transfuse 25 ml of norepinephrine containing 0.5 mg 1 kg norepinephrine from the right external jugular vein with 10 minutes. That means the first step, give your patient 25 ml normal saline and some norepinephrine. we see the vasoconstriction. The microcirculation is not improved while, and the blood pressure dropped down quickly. Then transfuse blood. Transfuse the all outdrawing blood back quickly and observe all the indicators 20 minutes later. You see, after blood transfusion, the microcirculation is improved. Some vessels are opening. And this group, compared to the second group, there is norepinephrine in it. Some microcirculation improve. The vessel begin to perfuse. But some vessels still stagnant. Stasis. The last group take arterial blood out to replicate hemorrhagic shock until blood pressure drop to 14 mm/colon and maintain half an hour. For this treatment, we will transfuse 25 ml of normal saline with anisotamine. Anisotamine is a vasodilator. Anisotamine. 25 ml normal saline containing 1 milligram a kilogram anisotamine from the right internal jugular vein with 20 minutes. After transfusion, you see blood pressure goes up. Some vessels begin to perfuse, but the pressure still lower than normal level. Then transfuse the all outdrawing blood back quickly and observe all the indicators 20 minutes later. And this is blood pressure after transfusion of blood. After blood perfusion, blood pressure goes up. Part 4. Discussion. In the experiment, we observe that the experimental results, including blood pressure, CVP, heart rate, respiratory frequency, and urinary volume, are different before shock and after shock, before treatment and after treatment, and between the different treatments. Now, blood pressure. After shock, blood pressure dropped down quickly. After treatment, blood pressure recovery. CVP after shock decrease. after treatment increase, and the heart rate after shock fast, after treatment normal, respiratory frequency after shock frequency become quickly. At the early stage of shock, the respiratory frequency became fast, and at the end stage of shock, it became slow. After treatment, normal. Urinary volume after shock, urine is reduced. During the shock, no urine. After treatment, the urinary volume increase slowly. And this is microcirculation changes and blood pressure. After shock, blood pressure decrease. And the treatment with blood transfusion or normal saline, blood pressure can be increased slowly to some degree. Both normal saline and blood transfusion, the blood pressure can be maintained at a normal level compared to the treatment with only blood transfusion or normal saline. After vasoactive agents, this is norepinephrine, blood pressure can be maintained at a normal level, but it will decrease. After blood transfusion, it can be maintained at a normal level. This is anisotropic. After application of anisotropic, the blood pressure can be maintained to some degree. And after blood transfusion, the blood pressure can be maintained to almost normal level. And we can draw the conclusion. The blood pressure, the changes of blood pressure doesn't match the microcirculation. Why? Why the rabbit manifest the different indicators before and after shock, before and after treatment, and between the different treatments? Now, let's analyze it. We know the key link of shock is not blood pressure, but the changes of microcirculation. Now, before shock, everything normal. After shock, the microvascular caliber is increased. After shock treatment, it returned to normal. The capillary openings after shock decrease. And during the shock development, the openings of capillary vessels increase. That means the vasodilation. After treatment, is normal. The blood flow velocity after shock slow. During the shock slow. After treatment, some treatment will make the blood flow normal, and some treatment will make blood flow quickly. And the next one, let's analyze the reason. Firstly, rapid massive blood loss of over 20% of total blood volume in rabbits will lead to hemorrhagic shock, characterized by decreased blood pressure (BP) and central venous pressure (CVP). Furthermore, the microcirculation also changes after shock. You see, this is normal microcirculation. This is the changes of microcirculation after blood out. And the normal condition, we observe the fast blood flow in the microcirculation of rabbit. In the early stage of arterial blood lighting, the microcirculation show light, both arterial and venous contract. This is arterial and venous contract. The vessel became contracted. smaller, and the capillaries closed. The vessel branch decreased. The blood flow slowed down. The microcirculation entered ischemic hypoxia stage. The pathogenesis of microcirculation changes include blood loss caused the lower ECBV, which lead to microcirculatory hypoperfusion with ischemic and hypoxia. Secondly, intense activation of sympathetic adrenal system and increased vasoconstrictors such as angiotensin II will cause vasoconstriction and further aggregate the microcirculatory ischemia and hypoxia. To say another word, blood loss will make ECBV decrease include hyperperfusion to the microcirculation. Secondly, ECBV decrease also make sympathetic adrenal symptoms to release vasoconstrictor and aggregate vasoconstriction and make ischemia and hypoxia. So for examples, renal perfusion, a kidney. Renal perfusion is insufficient and the urinary output is reduced because the kidney is reaching alpha receptor, which will combine to catecholamine and make vasoconstriction. So urinary volume will decrease sharply at the early stage of shock. Increase heart rate and rapid breathing are results of sympathetic excitation. Reduce ECBV and insufficient venous return lead to decreased CVP. Although sympathetic excitation maintains blood pressure or even keep it normal, the microcirculation is in an ischemic and hypoxia state. Therefore, the key to the occurrence of shock is not blood pressure, but blood flow as microcirculation. To say another word, in this stage, maybe blood pressure is normal, but microcirculation is a hypoperfusion, ischemia, and hypoxia. When the mean blood pressure drops down to 14 mm mercury column for half an hour, this means shock. The changes of microcirculation are as follows. The arterial and venous contracted and obviously and even began to dilate. The caliber was enlarged, red blood cells aggregated in capillaries, and blood flow slowed down. The microcirculation progressed to the stagnant hypoxia stage. The pathogenesis of microcirculation changes include acidosis, coagulation of local metabolites, increased vasodilators, and hemarrhagic changes. The heart rate and breathing are still fast due to intensive sympathetic excitation. In the serious shock, some rabbits may have slow heart rate and dyspnea because cardiopulmonary function is inhibited. Due to microcirculatory congestion, venous return and ECBV decrease sharply, followed by further reduction of blood pressure and CVP. Further decrease in renal perfusion will lead to anuria. Anuria means no urine. Next one, let's analyze the experimental result before and after shock treatment. Firstly, the first group only transfused blood or normal saline. After transfusion, blood pressure and CVP increased slowly. Heart rate and breathing slowed down, and urinary volume increased a bit. Microcirculation was not obviously improved because in this stagnant state of microcirculation. In addition to blood loss, the body fluid transferred into tissue space and cells from the vessel. Therefore, blood transfusion alone cannot completely restore the blood volume. The second group was normal saline and blood transfusion, which restored the blood volume, blood pressure, and CVP recovered. Heart rate and breathing slowed down, urinary volume increased a little. The blood flow velocity increased and the microcirculation was improved. The effect was better than that of blood transfusion alone. Due to the slow blood flow in the venule, the blood stasis and high post-capillary resistance in stagnant hypoxia state, sufficient fluid cannot completely improve the tissue perfusion without vasoactive agents. So that means the second group seems better than the first group, but the second group cannot improve the vasal perfusion completely. The next group is norepinephrine. Norepinephrine is a vasoconstrictor, is a common blood pressure booster. It mainly causes vasoconstriction and a rapid rise of blood pressure by the activation of adrenal after receptor. Due to vasoconstriction, the post-capillary resistance here. The post-capillary resistance was increased after application of norepinephrine, and blood volume was still insufficient. Microcirculation was not improved. Only blood pressure is increased. After blood transfusion, microcirculation was partially improved. CVP increased. Heart rate and respiratory frequency slowly recovered. However, the sustained vasoconstriction aggregated renal hypoperfusion, characterized by oligurin or anuria. That means after application of norepinephrine, we can make blood pressure increase, but it will aggregate vasoconstriction of kidney and aggregate less urine formation in the kidney. Although norepinephrine can increase the blood pressure rapidly, it should be used on the basis of full expansion of blood volume. To say another word, if you only use norepinephrine without any blood transfusion or infusion, you cannot improve microcirculation. Anisotamine is vasodilator. It can relax vascular smooth muscle. When blood volume is fully restored, anisotamine can dilate small vessels, relieve the microcirculation congestion, increase the velocity of the blood flow, restore the perfusion and some blood vessels, and improve the microcirculation. So for the hemorrhagic shock, which is in the second state, stagnant hypoxia state, we can use vasodilator to make a vasodilation and remove the waste out of the capillary and restore perfusion. But if you use vasodilator, it will make a vasodilation and make blood pressure drop down. So the precondition of application of vasodilator, we should infuse enough blood or normal saline to the patient. On the basis of completely expansion of ECBV, we can use vasodilator. So blood pressure, CVP, heart rate, breathing gradually recovered after application of vasodilator. Renal perfusion was improved and urinary volume gradually increased. And fully understanding the pathogenesis of shock will contribute to the prevention and treatment of the disease. In clinical practice, we should make reasonable treatment principles according to the different stage of shock development. If you have any questions, we can discuss it after class.